Welcome to Mastering and Guideline in Ultrasound and Echo. Hi everyone, here is another important and common question and many times confusing topics, and it is why we have differences volume and ejection fraction measurement in apical 4 and apical 2, and how much differences is acceptable. What about those situations that we have wall motion abnormality? And in those cases that discrepancy is too much, as not acceptable, what option we have and what should we do? Now let's go see what is explanation for them. As you know, left ventricle shape is almost conical or hemi-ellipsoid or almost a bullet shape. Here you can see a 3D image of the left ventricle intra. And based on the math, we have many formula and equation to measuring volume of the such shape. As you can see here, we have Simpson rule that use this technique, ellipsoid biplane, ellipsoid, and so on. But the one technique that has been approved and recommended by all committee of the echocardiography in all society is modified Simpson. In modified Simpson or method of the disc, the left ventricle divided to 20 in most of the software to 20 disc with equal height of disc, as you can see here, just with tracing of the endocardium and length of the left ventricle, machine automatically divided to the 20 discs, and each disc has been calculated volume by this formula, and finally the summation of those 20 with this formula and adding this formula between and 4 and 2, finally machine give us the left ventricle volume, and after that by those end-diastolic and end-systolic measuring give us ejection fraction. That is our assumption, that first of all is almost bullet shaped left ventricle, and the base of this left ventricle, that is mitral annulus, is perpendicular to the left ventricle length, as you can see here. This is two assumption that is in some cases bring some error that I am going to explain later. As a general rule, the differences the volume of the left ventricle between apical 4 and 2, if it's less than 10%, is acceptable. For example, if left ventricle volume in apical 4 was 100 milliliter and in apical 2 96, so is that even less than 5%, so is that acceptable. About the ejection fraction, the differences should be less than 5%. For example, if it's at the apical 4 we got it 58% ejection fraction, in apical 2 we got it 56, so still is less than 5%, is acceptable. Otherwise is not. There are many reasons. There are four main reasons that there is too much discrepancy between measurement apical 4 and apical 2. At top of them is one, foreshortening, and as I explained in another lecture or two lectures, foreshortening can be defined by oval shape, or instead of oval shape, a bullet shape of left ventricle and all of the heart. In foreshortening is close to the round, and left ventricle lose the bullet shape, and the tip of the apex myocardium is a little looks like thick, unless the patient has hypertrophy, and during systole endocardium of apex move too much in. Or the same rules for the apical 2, it goes there. Another one is that we have a wrong view, means in apical 4 Instead of the correct apical 4, we are a little basal view, or close to the 5, between 4 and 5. As general rules, you shouldn't see LVOT show up here a little. So it's between 4 and 5. A little you have to fan it down. And all four chambers are at their largest size at the same frame, all of them. That is another rules that you know this is correct view. In apical 2 is the most important technique for getting correct apical 2 is that we get it from apical 4 first correctly. For that purpose, we have to bring apex of the heart at the center of the sector. Here is a little too much medial. We have to move our probe a little medial this way. That become correspond exactly parallel to the left ventricle axis. When we move a probe to the medial and make it exactly at the long axis of the left ventricle, in that case, we just twisting counterclockwise until we lose completely right side and get all those criteria that I explained. 100% we will be on axis of the left ventricle in apical 2. Here I have to mention, as you notice here, in this case, the left ventricle axis is not parallel and the same as the left atrium axis. Here, this is left atrium axis, this is left ventricle axis. They are has angle between them. So in that case, just remember extra tip that when you go apical 2 in this for left ventricle on this green line, that will not be correct for measurement the left atrium and two chamber. For the two chamber left atrium volume, you have to go a little lateral and make it correct axis of the view for the left atrium. In other words, in many cases, you have to get different view for one time for left ventricle, another time for left atrium. Another reason that we have too much discrepancy between those two measurements is wrong tracing. I explained this in many clips you can go with. That is another reason. And finally, when we have wall motion abnormality, that is the logic. If in that view we have wall motion abnormality, 100% ejection fraction will be lower than the other view that doesn't have wall motion abnormality. In those cases that we have very hard time, and especially endocardium tracing is very hard and we cannot get it correctly, or discrepancy, we cannot explain why. If we have access and have good window, we can use a 3D that is the better than 2D. In some study, it has been shown that instead of the apical 2, apical 3 is more reliable, more accurate than apical 2. So instead of the apical 4 and 2, those studies show with comparing MRI and 3D that apical 3 is more reliable and more accurate and less error than apical 2. For that purpose, just we go get it correct apical 3, then we put it our two landmark on the one of them posterior mitral ring and anterior aortic ring, and then we trace it our left ventricle. They are in diastole and systole, and it give us more correct than the apical 2 chamber. But it still is not recommended by any of those societies. So just keep in your mind, if you practice, it's not bad idea, practice and see which one is on your case will be more accurate and more sensible and approvable for by all every measurement. And don't forget again, when you do those any measurement, always correspond with the other finding and your eyeball guessing. Eyeball guessing, when you doing, you have remember I had 3 clips about that. So correspond your finding with that is very helpful. You know, okay, is that right or not? At least you go and make and fix the mistake. And another one that I forgot to mention is that whenever you acquire any images for any purpose of measurement, doesn't matter 2D or Doppler, try to acquire and capture those view and picture when the patient hold his or her breath. In that case, we know that our image and our view will not be off axis during respiration. Another reason that sometimes we have our measurement doesn't correspond by eyeball guessing and other finding is when we have a slanting basal of the left ventricle. Means generally most of the patient, the base of the left ventricle is perpendicular to the lung axis of the left ventricle, like this. But in many cases, we have slanting or oblique of the base of the heart, annulus, compared to and related to the left long axis of the left ventricle. They are not perpendicular to each other. So in those cases, there are three techniques. The one that we use it by Simpson is this way. As you can see, Simpson's biplane, it measured and based on our tracing, it selected, make it many cylindric. In this case, usually this type of the measurement by the Simpson, the or disc technique, it underestimating left ventricle volume and ejection fraction. Another way is a truncated basal cylindric. In this case, we can measure this one. It is overestimating left ventricle volume. The best technique that Dr. Chu Kim and colleagues show and prove it, that is the basal oriented disc. So in that technique, the left ventricle, the disc make parallel to the base of the heart and then calculate it. This one is more close to the reality and correct and less error, but it still is not recommended, and we don't have technical adjustment for our measurement in our machine, not yet. Maybe later, sooner, they add on this type of the measurement too. At the end, I would like to add another tips in related to the measuring Simpson and ejection fraction, and that is the M mode of the mitral valve and S prime or systolic velocity of the annulus of mitral valve. In those cases that you don't have very clear endocardium and you want to guess and correspond your eyeball guessing by reality and measurable ejection fraction by accuracy, uh, and you don't have access to the definity, or it's not indication for sending patient to the MRI and all those stuff. Instead of the Simpson, we can use these two techniques together, and with accuracy of 90 over 95%, if we use both of them, we can calculate ejection fraction is above 50% is or below 50%. Just it's not bad idea in all those cases. Do M mode of medial and lateral and S prime of the medial annulus, and it give you very good indication and criteria for the function of the left ventricle. Those numbers are here. You can pause it and study by yourself. I hope it was useful. Up to the next time. Have a wonderful time.